Can you see the screen now?
Yeah, we can see.
We can see.
Okay, so I know that this is a very unknown territory for us. We are naive about the disease. And so the topic is well thought and chosen by Dr. Venugopal and Dr. Kunju Moideen, who have really taken the effort to sort of get all of us together. And I hope I will be able to do justice this afternoon, a Sunday afternoon for you all. So I think it's know, prepare, and protect ourselves. I don't know whether how many of you in the country knew about this city called Wuhan, Hubei, China. I think for me, it was an unknown place on this godforsaken land till history was created on 31st December, when China notified of the outbreak of the COVID or the SARS-CoV-2 infection to the world. And within a matter of weeks, after 1st December, where the first case was reported, WHO identified this as a pandemic. So moving from an epidemic to a pandemic took no time. Now, as the story unfolds each day, and the story is, or the news is unfolding, there is new knowledge being added every day. I think as practicing gynecologists and more so obstetricians, we need to keep ourselves updated with not just the dashboards, but also what we understand of the disease, what we know, and how we can help the patients. I hope my slides are clear there. Are you seeing the slides clearly, Dr. Venu and Kunju?
Yeah,
Clearly,
it's very
clearly.
clear, very clear.
Okay, so I think I'll just adjust my slides. I'm not seeing my slides very clearly because, okay, so we'll go ahead and saying that January 30th was what WHO declared it a public health emergency. And of course, within a matter of weeks, on March 11th, it was declared a pandemic. Now, I thought I could create a dashboard for COVID and pregnancy. And so I looked up the statistics that I could get. I looked up all the case reports. And what I could get, even till 8 hours before, there was a case which was reported from Korea. Though it was a patient who delivered earlier in March, but she was accepted, the paper was accepted recently. And I can't say more than 55. There'll be definitely more than 65 now, women who have had pregnancies, which have reported in English literature. I'm not talking about the French and the, Chinese literature. And if you look at it, 39 of these cases have come to Asia. We can't deny that China has been the major contributor because the disease started from the wet markets in China. And there's one case from Korea. If you look at the slide, all these hospitals are from Wuhan. One from Fudan and one from Suzhou, and the latest which has been reported from Asia is from Daegu, Korea. But if you look at the joint WHO-China mission, they have contributed to almost 147 pregnancies, though case reports are from 39. Now, we should understand this virus because I think when we did undergraduate, postgraduate, or even recent, we did not know much because it's a very novel virus. So it is one of the 7th of the coronaviruses, the others being the ones which cause common flu, the SARS, which caused an epidemic, the Middle Eastern Respiratory Syndrome, the MERS-CoV, as it's called, which were understood until 2009 and 2013 outbreaks that they did. So this is a RNA virus, which is an envelope beta coronavirus, which is known to be going from human to human transmission. The virus is present in the respiratory mucosa of the nasopharynx, and that's where it goes and attaches. We have been having a lot of debate, but now I think with WHO, CDC all agreeing that it's an aerosol-based infection when the person coughs. And then when this, droplets go far, it's fomites, which are actually responsible on the surfaces to which it adheres. Though the fecal-oral route has been defined, but it is rare. And what we've heard from our clinical colleagues and also from the virologists, the incubation period of this disease is average 5 days, a range being 2 to 14 days. But it's very important again to understand that the transmission is mostly in the second week. I say mostly, it can even happen beyond the second week also, because that's the time when the viral shedding is maximum. Now, all that we can understand and we need to understand is that the putative receptor of this virus is the respiratory epithelial cells through the ACE2 enzyme, converting enzyme, which attacks, and these ACE2 receptors are present maximally on the alveolar cells of the lungs. However, they've been described at extrapulmonary sites. And what's interesting that we come to know that the ACE2 sites or receptors are lowered in females. And therefore, whatever data we're getting, mind you, from the hospital admitted patients, men are seeming to be more infected, or there are more cases admitted in the hospitals as males than females. And this is perhaps the reason, because there are a lower number of ACE2 receptors in women. Now, this is how it attacks. It goes and takes entry. The virus multiplies, and once it goes and acts on the ACE2 inhibitors or ACE2 sites, it sets the action going. So the SARS-CoV-2 virus entering into the respiratory system, going into the lungs, replicating there, and then it sets up the antigen-antibody response, which is both cellular and humoral. And when the disease progresses, when there's a cytokine storm, we can say that the patient gets to more severe or critical form of disease. And that's how we are understanding. I thought I'll just tell a little bit of this before we really move to pregnancy. Of course, all I've been hearing these, the symptoms being fever, cough, fatigue, these are the most common symptoms. And if we were to understand, the disease presents in its milder forms or asymptomatic forms in 80%. Now, mind you, when we're saying milder forms, they are symptomatic. And there is an entity which is called as asymptomatic and also pre-symptomatic. Now, that's the real burden of disease for all of us as, epidemiologists or as healthcare providers. And that's a big burden which we are not able to sort of know till we do putting everybody to a testing. But when there's a disease, we have to understand that this is going to be critical or severe in just 15 to 5% of cases. And these are the ones which will actually be going to the ICU and will require more critical care. Now, having said that, I think we have to understand that the classification of COVID, this is now from, the CDC puts as mild, moderate, and severe. But I think there's lots which has come from the Chinese CDC, which is the Chinese, Center of Disease. And they have divided the mild into moderate, because I think most of the data that we are getting and most of the publications, you'll not believe, in just a matter of 2 weeks, you get 800 publications on COVID. I think how rapidly most editorials are accepting papers and most data is coming. So we acknowledge their classification, therefore. And mild is somebody who just has mild symptoms or may have no evidence of pneumonia on imaging, to a moderate who has symptoms of fever or cough or breathlessness or a milder degree. And then with these symptoms, there is also a manifestation on imaging of features suggestive of pneumonia. Severe is when the disease presents with dyspnea, there's hypoxia, and when you do CT imaging or X-ray, you find more than 50% of the lungs are involved. As against a critical is an individual who's in respiratory failure, requires to go to the ICU, mechanical ventilation, and or is in shock, which could be multi-organ failure. Now, as clinicians and obstetricians, we are to be concerned, definitely. Why are we concerned? Because we are naive about the disease. We don't really know the disease, how it behaves. And we have just information from few case reports or case series. But then when the Chinese saw this disease, they had got lessons because they had seen the pandemic of SARS and MERS, and they felt that this disease could behave. Now, why were they really worried is because if you look at the epidemic and you go to the outbreaks of the SARS and the MERS, the disease in pregnant patients was disproportionate. The respiratory symptoms are far more. These women required 3 times higher incidence of mechanical ventilation. Almost 33% of these patients with these previous epidemics went to the ICU. The case fatality was very high. And of course, there were a lot of first trimester miscarriages. Now, mind you, this was with what they observed. And therefore, there was a concern. Now, having said that, the disease in pregnancy with COVID is not as severe as this. The fatality is lesser if we look at it in terms of COVID. But then what's more striking is that the disease is far more infectious as compared to SARS and MERS. Now, what are the issues that I would want to address here? And they are issues which I think all of us as obstetricians and clinicians are concerned. Are pregnant women at high risk of getting infected? Yes or no? And if they're infected, is the course of disease the same, or it'll be different from somebody who's non-pregnant or somebody who's pregnant and not infected? Then what are the complications? Does she suffer the same kind of antenatal problems, or she has intrapartum problems or neonatal complications? And particularly, what we are worried as clinicians is when they go into labor or they're in the 3rd trimester, what are their chances of having a preterm labor, growth restriction, or an IUD, which was seen more common with the MERS and the SARS? What about vertical transmission? Because that's our big worry, considering that the disease is so infective. Should the timing and mode of delivery be better understood, or should we need to sort of fine tune it in light of the disease? And what are our intrapartum management plans do we have? What about breastfeeding? And very important, as I said, how do we protect, not just protect our patients who are not infected, but also the healthcare workers, including the physicians who will be guiding the whole team and staff. Now, I just thought before we really go on to talk about how the disease affects, let's understand what the pulmonary functions in pregnancy, because the disease is affecting the respiratory system. And therefore, we know that the pulmonary functions are definitely altered because there is a diaphragmatic splinting. As the gravid uterus keeps moving up in advanced pregnancy, there will be a reduction in the functional residual capacity. The total lung capacity also decreases. So do the end respiratory volumes and the residual volumes. So with this thing in light, I think one would really anticipate that if it's a COVID pneumonia, it will definitely go more profound. And also this will predispose the woman to more hypoxic respiratory failure in pregnancy as compared to somebody who is not pregnant. What about the immune system? You know, the whole game plan or the whole gamut of events that are taking place with the COVID infection is the lungs, and they bear the brunt of an ARDS, which is so different from the other kind of ARDS, is that it's a totally immune modulated disease, setting the humoral and the cellular immunity into a turmoil. Now, the thing to really worry is that pregnancy is a Th2 system state. You know, that's the state of dominance, the T helper 2 systems, because why this comes in? Because it wants to protect the fetus. And if we understand this disbalance, which is in favor of the fetus and implantation and pregnancy continuum, is not very well suited for an infection, which could be any kind of infection, because it's the Th1 immunity, which is basically microbicidal. It gives you protection from microbes. And the Th2 is basically an anti-inflammatory response of the body. So if you think like that, then the mother will be more vulnerable to viral infections because the system, which is Th1, which contains or controls the infection, is actually relatively lacking in a pregnant woman. But then this is what we understand. And the other thing, which I think a lot of researchers have put their minds, and I also kind of reviewed it, was that a Th1 response which occurs is an elevated IL-6, which is seen in most patients who are critically ill, who are terminal in the COVID infection. Now, this is the one which is found to be very high in people who are dying in the ICU. Now, this particular IL-6 is not the one which gets elevated in pregnancy by virtue of the Th2 response. Therefore, if we look at it, there is a silver lining to this kind of physiology in pregnancy. So if the disease occurs, it is of less severity in a pregnant woman as compared to a non-pregnant woman. So if women are more prone to infections, the severity of disease is bound to be lesser. So this is one thing. But I think if you look at the immune system, which is being really studied and is being really researched with a lot of profound depth, is needing more detailing when it comes of gravid or non-gravid women. Now, considering this, is pregnancy a special situation? Well, there is another problem which we have to understand, that there's an entity called an estrogen-mediated hyperemia in the later pregnancy, which causes something called a gestational rhinitis. And there is definitely more nasal congestion, there's rhinorrhea, and there is always a consideration which we clinicians would feel that many times women complain of blocked nose, difficulty in breathing. And this can be taken as physiological and always can be mistaken, and therefore can lead to a delay in diagnosis. So putting all these things together, if you think the respiratory and the immune system, we would always think that the women who are pregnant are more susceptible to severe infection and hypoxic compromise. However, if you look at all the data that has come up from the studies that have available or the case series, pregnant women are not more likely to contract infection than general. So having said that, this is what is the essence, that they are not at a greater risk or a greater chance of having infection. Now, the next thing is, so if they have an infection, it's milder as by the physiology. So let's look at the fetus. What are the fetal risks? Well, this is the data which has come from all the pregnant patients that have delivered or have miscarried. There's a very small chance of miscarriage as of the studies or the reports that have come up till date, as contrast to the MERS or the SARS. However, there was a high percentage of fetal distress in the Chinese group of patients. For the 19 patients that they had, 8 of them had fetal distress during labor. Now, again, the next thing is after the fetus, we move on to the neonatal effects. Now, on the neonate, this was in fact a study which basically looked at the vertical transmission risk, because from this study, which you look at is 10 neonates were born from 9 women. There was one set of twins. And if you really read at the methods, it was actually a retrospective data which came from 10 neonates, including 2 twins who were delivered. There were 4 full-term infants and 6 were born premature. Out of these premature, 6 were actually small for gestation ages. And when they looked at, they found that the neonatal effects were there. Most of their babies who were preterm actually needed admission to the NICU. They had fever, they had respiratory distress syndrome, needing them to be given oxygenation. There was thrombocytopenia, even abnormal LFTs, and there was mortality in one child. Now, we don't know whether we'll put this to COVID per se, because none of the newborns showed a positive COVID on the nasal or the throat swabs that are taken from the newborns. So perhaps this could be an effect of prematurity, and we are very early to say because this paper came in the February of 2020. Now, the other risk that is really concerning, like any viral infection, is the risk of vertical transmission. I think this has been the major concern, which is the major contributor is the study by Chen. And I think Chen has contributed tremendously. This is a paper which has come in Lancet, and this was a hallmark paper where he looked at 9 women. And what they did was, when these pregnant women were delivering, all in the 3rd trimester, they did cesarean section for simple reasons, that there was not just an obstetrical indication, they were fearing a vertical transmission, and therefore to obviate that risk, and also they were naive about how to manage the disease, they took all the patients for a cesarean section. At the time of cesarean, they drew amniotic fluid from in a syringe before giving an incision on the uterus. And what they found was that they could not isolate the virus either in the amniotic fluid or the cord blood or even in the neonatal throat swabs. So this study clearly said and proves that there is no vertical transmission, just like the previous study or previous data, which comes again from China, Wuhan, of the 10 newborns. But then we have to understand, it's too premature to say, because as more data comes in, the big caveat is that all these women had been delivered by a cesarean section. They were all around 36 to 38 weeks. So we really don't know. We'll get more and more data and we'll get wiser. So currently, the evidence says that intrauterine infection does not lead to, or there's no intrauterine infection and there's no vertical transmission for COVID pneumonia if the woman gets a COVID pneumonia in late pregnancy. Now, then it is what we're understanding, that this is what we have got a backdrop and knowledge. The next thing is, if we have a pregnant woman and we'll say, are we testing all our pregnant women? As would think in a place even like Korea, where they have gone so massively into offering testing, they haven't offered every pregnant woman. And I was reviewing their literature as well. Now, who are the women who should be offered testing? Because pregnancy is a special group, unlike the non-pregnant individuals and non-pregnant women or men for that matter. So definitely the guidelines that have come again from the WHO China joint commission that they have put together, they said that woman who's pregnant and if she has an acute respiratory symptom, i.e. she has fever, she has cough, or she has shortness of breath, if she has traveled to recently abroad. I think in the later days this data may not hold, this guideline may not hold true for India, because for the last 10 or 11 days we've had no international travel allowed. In addition, if she has, to this testing, she's had a household contact who has been quarantined for 14 days and she stands a chance to get a testing, or if there has been a close contact of any person, and this means any healthcare worker who's a laboratory person or a healthcare worker who is pregnant and is managing patients who have respiratory illness, this pregnant healthcare worker merits a testing for COVID. And again, very important, a pregnant woman who's presently asymptomatic should be tested between 5 to 14 days of coming in direct contact with a high risk contact of an individual who has actually tested positive. Now, this is something which is different from non-pregnant people, because in non-pregnant, you may not, but in some countries, but this is something which is different. A pregnant woman definitely merits as what I've highlighted. Now, if we are supposed to offer a testing, let's see what are we offering. Of course, the gold standard is RT-PCR assay, which is available as kits. And I think now every country is going on against to have their own indigenous kits. Now, why should you take the swabs? It's recommended to take nasopharyngeal swabs because they are the ones which hold more merit. Though an oropharyngeal swab can be taken, but it's not essential because the earlier guideline from CDC said at least 2 swabs and at least 1 negative, again a repeat after 24 or 48 hours. Now, a good nasopharyngeal swab, particularly from the mid turbinate area or the mid nasal turbinate, is good enough. And again, as you read from the Lancet papers, they said if sputum is there, only then it should be sampled. You should not ask the patient to induce sputum. That would not be the right way. So having said that, the RT-PCR which is a gold standard, is also being recommended and is accepted by the AIIMS. However, AIIMS is going ahead even with the antibody testing, but mind you that antibody testing will be screening, and whether we'll be able to apply to pregnant patients, we are not very sure. But having said that, we must understand there's still a false negative, which can be there up to 10 to 30% of patients who even have 2 serial swabs. This is what we have to understand. Now, the next thing that you should offer is, and that you'll offer not to a patient who's asymptomatic, and definitely not to a patient who has just mild fever or very mild symptoms, but if there is an evidence and which really strongly corroborates, is doing an imaging. It's in the form of X-ray chest, but I think here a CT scan is definitely superior in terms of its positive predictive value and also in terms of its accuracy, because a CT chest gives you a typical ground glass opacities of consolidation which are present bilaterally. Having said that, if you don't get bilateral, doesn't mean it's not a COVID pneumonia. In fact, in the reported cases, even in pregnant patients, they found there was unilateral pneumonia also on the CT images. Now, again, there is a very big fear. Clinicians may say, should we subject our women to a CT scan because there is an exposure to CT? Well, if you look at the radiation exposure with the routine CT chest, it's just 0.03 milligray, which is much lower than the safe limit of being lesser than 50 milligray. So it's not associated. And also iodinated contrast media do cross the placenta, but then you're giving it one time. And these studies that have been done in the 3rd trimester. So the risk of malformations in the fetus or teratogenicity or any thyroid dysfunction in the newborn are rather, not very, very fearing. So having said that, do we understand that we are going to do a CT in every patient? No, but if you look at the series in Lancet by Chen or by Zhuang, and when they had their patients, they had patients who had moderate disease, who were running fever. In fact, they got CT done in all their patients, even the ones who had fever develop in the postpartum. So again, this is something which we have to understand, that whom we are going to subject to CT scan. Now, what about the other testing? Because once she's there, I think this is again has to be on patient basis. You can't subject everybody. Of course, with fever, we'll be doing TLC, DLC, but we must send their liver enzymes, get their LDH done, CRP, ferritin. Now, these are all these which have been there for, not specified as such for pregnancy, but they have been mentioned by the WHO CDC guidelines to be recommended once the patient is testing positive for COVID, because they will be an indicator of severity. But a big catch here, what the CDC says, the D-dimer and lymphopenia are related to the terminally ill patients. We have to be very cautious because D-dimers are as it is raised in pregnancy. So, you cannot take D-dimers as a prognosticating marker in pregnant women. Of course, procalcitonin is increased in women who are there in the ICU, which was seen in some cases. And of course, there are a whole lot of inflammatory markers which have been mentioned for patient out with pregnancy or in men, but then can we really use them because we know there's an altered state? As I said, IL-6, which is actually a marker, is raised in TH1, may not actually corroborate with women who are pregnant. So I just thought I will just get hold some of the interesting articles which have come. If you look at it right from top to bottom, they are all coming in NEJM or Lancet, and they're very small cases, from Wuhan and other parts around Wuhan. And they are just not more than, if you look at the number, 9 cases on the one top by Chen, 7 cases of pregnant patients, all neonatal and obstetric outcomes, and an analysis of 10 neonates, which I mentioned, and just a recent pre-proof, which is coming again from China, of 13. So if we put it on the dashboard, with 147 pregnancies, I think this was what I updated on 26th March. But as I said, if I go on to update, there'll be close to 60, 65 patients who have been reported. Now, if you look at this data from China, what do we really get? Let's look at the assessment. While we are understanding that there is a high risk group as WHSOs, patients who are immunocompromised, as patients who are on some kind of drugs, and if case puts elderly, we'll realize our patients are all young because they are pregnant. And therefore, if you look at the women in the age group of 24 to 40 years, they were all in the third trimester, and that's what they got. They did not have comorbid conditions in all the data that is pooled from the 147 pregnancies. They did not have an underlying comorbidity, I mean an underlying hypertension or a predated diabetes or any other comorbid conditions, but few of them, including 4, developed gestational hypertension, preeclampsia, or GDM, but that was not at the time when they got the corona or the COVID infection. Of the maternal outcomes, you say they had just 1 patient from the entire series who needed ECMO or extracorporeal mechanical ventilation. Only 1% had critical disease, 8% severe disease, and 91% had mild to moderate. And when I mean mild to moderate, who needed an ICU care on mechanical ventilation. All of them have delivered by cesarean section. So the Chinese population, by and large, is data which is coming cesarean section per se done because they wanted to prevent the vertical transmission. They were not very sure because they didn't have experience, and also there were obstetric indications like there was previous to cesarean section or there was a CPD. But the interesting bit that comes from there is that there's been no COVID positive neonate at birth. And if there is a mortality of 1 neonate or 1 infant, that is per se because of prematurity. So again, if you look from this whole data that has been assimilated and analyzed by the CDC from China, they say pregnant women are not at a high risk of developing severe disease. So that's a reassurance which we should understand. So to sum up, the pregnant women are not at a risk or greater risk of getting COVID. If they have, they will not suffer a severe disease. At the present time, vertical transmission is not being documented. We don't know what is the data which comes in 6 weeks from now, or maybe 2 weeks from now. And the babies and the young-born children, if they do get infected, which was seen in 3 neonates or infants, 3rd or 4th day, they had a milder form of disease or milder. So having understood this, let's now understand what will be our preventive measures. What are the preventive measures for pregnant women who are actually not? So when we talk of prevention, we talk of people who are not infected, because a large, or in fact, almost most of our women who are now at home quarantine, so-called quarantine, are not infected as we understand, and they are worried about their pregnancy, and more so about us and our healthcare providers, how we have to take care of them. So I think I don't need to reiterate, but this is something very important, that if you have a teleconferencing facilities or if your patients are calling, whatever is being said on the television or is being, we have to reinforce social distancing, they have to work from home, disinfect your surfaces, avoid, this is not just the FOXI guidelines, but also come from the WHO and the CDC for pregnant women. They have to avoid gathering, minimize the visitors who are coming to a woman who has delivered and is at home also. So make sure of that. Now, coming on to the antenatal, I think a big worry for us is we all are in the lockdown, and I'm sure patients are calling you, me, all of us, doctor, my appointment was scheduled. It's been over 2 weeks now. What do I do? I'm worried. And I think that's what we have to tell them. We are deferring routine visits. Now, the idea of routine deferment is basically we want to maintain or mitigate the disease as is by the whole, the larger picture of things. We don't then want them to sort of undo the social distancing and the good efforts we are doing. And in case they're coming to a crowded place, their chances of getting infected from an asymptomatic carrier cannot be ruled out. So that's very important. And I think something where the telehealth strategy, and I'm sure, Kunju, you've put it here, you will be doing much more business with your patients on telehealth strategy. So telephonic consultations and the web platform is something which we have to resort to, because we don't know when the lockdown will be called off. And of course, you have to take their questions, but then minor ailments or minor problems can always be dealt with. I mean, minor means non-respiratory, non-fever, or non-febrile. Well, of course, we have essential milestones which have to be taken care. And this is what even our FOXI guidelines had put it. Patients who are moving closer to the 3rd trimester, their worry is anti-fetal surveillance. And I will tell how the Chinese have drafted their guideline on the visit. And that was really amazing. And of course, how we can schedule the visits. What about the antenatal ultrasounds? The only thing that has come very clearly from the CDC, if you go to their frequently asked questions on physicians, they are giving very clear guidelines to their physicians. And they're saying, please postpone all elective ultrasounds. I know there's mayhem in US. And the way situations are with sort of areas on the New York or the East and the West Coast, I think they had to be very categoric in defining what is elective ultrasound. They have put a list. They have also told that they have to be limited road scans. Please limit them. Unless and until it's really mandated, it is the clinician who has to have judgment enough to decide who needs a high-risk monitoring, and only those who need an urgent NST and Mannings have to be taken when they are in the third trimester. Now, this is something which I found very interesting from a paper which came in Journal of Medical Virology. In fact, this paper actually is a mix. It's a mix of paper in which their women came to the gynae casualty for an ectopic pregnancy, ruptured ectopic, then was tested positive with an antenatal patient. And then in their discussion, they added that how they have made the antenatal plan in China. And what they say in the first trimester, there's just one visit. In fact, the Wuhan obstetricians have said, don't visit us until you're 11 or 13 weeks. Just go for an NTNB. In the second trimester, again, the Wuhan hospital says one, and that visit is a 2021, where you get a detailed anomaly scan. And this, mind you, this is all for a low risk obstetrics. It doesn't mean for somebody who has high risk, because they're also trying to keep women away. And in the third trimester, just saying, come to us at 30 to 32 and 36 to 37. Besides that, it's not saying they're not attending their patients. They are on teleconference. And what they have done, which was very nice, they have done videos and they have used TikToks and all models, and they have trained their patients to take their own fundal height, take their own abdominal girths, and send it back to their doctors. So, you're kind of doing the patient is herself her own obstetrician or a midwife in a way, and she is getting back with the fetal movements as fetal surveillance charts to their clinicians. So I think they're really involved. So of course, I will not tell about this. This can be skipped, how you can prevent. Now, when we come about management issues in the hospital and your maternity service, I think we have to really, really look at the managerial aspect before we kind of start moving ahead. And the management would be your infrastructure and your human resource. Both have to be sort of well prepared. Yeah, there'll be people who are having good number of deliveries and now they don't understand how to go about because they don't have a COVID hospital. And I think there are very beautiful, managerial guidelines again coming from the European CDC and even from the CDC, which say you have to create a facility within yourself. And this management aspect can be taken from their sites. You have to identify an area where you will have your triad site, where you will know which patients you will be sending to a hot or a COVID area or the cold area. But then there will be some of them who will be, not defined, who will have symptoms, who are still not positive. So you have to have a receiving area which has to be separate from your defined area. Of course, creating an isolation ward for an OT is very important. The understanding of decluttering and having your, adequate disposition sites. If you have a COVID positive, where will you dispose? All these things should be defined on the site or where you will handle. And of course, even before you triage, before your patient comes in, you should have your helpline numbers where you will tell patients you have these symptoms. And if you are not having labor, better stay away, better be in quarantine. And for your human resource, I think it's very important that there should be protocols in place, which all bodies, POGS, RCOG, ECOG have clearly put. And your staff should be adhering. They should be well versed with your SOPs. Of course, the training is very important, and you have to adhere to the strict infection control guidelines. So what are we talking about? The healthcare? Of course, they will be told and they should be trained that when the patient comes, even if she is not a COVID, she is suspicious, they should maintain distancing because we don't know who's asymptomatic. Of course, we have to make sure that your consult rooms or examination room have the least amount of essential equipments or trolleys, etc. And of course, if there is a patient who has respiratory symptoms, all of you should be wearing a surgical mask, including your safai wala, your orderly and ward boys, or whosoever's around. They have to be, because they're equally precious and equally important at this time. So there is the way we triage. You have in your labor wards or your labor areas before they enter, I think there is a place where you will have a clean area. But before your patient can go to clean, I think a lot of triaging can happen on the telephone. That will be a good idea. But outside your labor ward, as we have done, a little distant away, we have our residents with a social worker, well prepared to handle them, ask them questions, and the questions are very clear. And we'll tell you what are the questions that you should ask, not just of fever, of travel, symptoms, your history of contact, and all these things, including if they've traveled abroad, if there's again a health worker who is caring for a COVID patient, again, should be considered potentially, infected. And all those where you're awaiting the results are all the ones which need to sort of wait before they can be directed to the hot or the cold areas. Now, this is an algorithm. I don't know, it looks a little crowded, but I've taken from the ACUG, and it's very nice. I think they have really made things very simple, because if you get a patient, and this can be done telephonically, if you assess the patient for symptoms, that means she has symptoms, i.e. cough, difficulty in breathing, fever, or GI symptoms. If they don't, then they just go to the routine prenatal care. That means limited antenatal visits. And if there is a patient who's laboring, goes to your cold area. But before that, I think we'll have to, this will also be undergoing a little change. If you see, if she meets some of the symptoms, you have to assess the severity, gauge from what is the amount or what's the degree of fever, what is the difficulty in breathing, does the patient cough more than, in fact, they have been so objective to define how much is the cough, and if she had, pressure, or they press on the chest, if there is any symptoms, if she coughs, does she have pain, which increases with coughing, does she show signs of dizziness? So, they have given objective symptoms. Each and everybody ticks that. It's there on their labor, triage areas. And if there is no positive answers, then again they assess for any comorbidities, including hypertension, diabetes, asthma, lung diseases, kidney diseases, any blood dyscrasia or immunosuppressors. I think this is something which we all can have a template done outside the labor wards. And again, if it's not there, none of them there, she definitely is a low risk patient who can be managed from home. If she's not laboring, she can be given hydration, even if she has mild fever. Of course, having said that, you have sent her tests for COVID, you have investigated her, sent her nasopharyngeal swabs. But if there are anything positive, then she moves to the high risk zone, and then she has to be seen immediately by the COVID team or an equivalent who sent her. And before they refer her to a person of undefined, identity, or the investigations are not clear, she still has to adhere to all the infectious control protocols and should be attended by people who I will share you in shades of the CDC, which say a level 1, level 2, or level 3 or PPE. So they have to. And similarly, if any of them has a positive answer, she moves to a moderate risk. Now, having said that, when they have comorbidities, if they have any obstetric issues or preterm labor, we have to not just do a clinical exam. We have to take their lab test. Their pulse oximetry is very important, because that will be the first thing that you can pick, and very important. If not a CT scan, an X-ray, chest, and ABG, this is indicated. So these are some things which I think is a very nice algorithm, which I felt, unlike the RCOG or the FOXY, is not so detailed, and something which is nicely given. So likewise, the patient will be reviewed by the to isolation, and the area, if she is to be put in, has to be defined as a negative pressure area, and the infection control has to be minimum. So if we look at it, this is a standard PPP, which are low prevalence, which probably could be worn by people who are having a shoe covers, have waterproof gowns, where they are receiving or triaging people. A high prevalence area is something which would be people who are there attending on the labor ward or around, but definitely if there is an enhanced PP would be for a confirmed case. So, your hot zone patients, we should have health workers, nothing short of enhanced PP with, and this should all be in a negative pressure room. That is what is the recommendation from the CDC. Now, let's look at when there is a woman who has a COVID infection, which is confirmed, or she has symptoms which are respiratory. What are the treatment modalities and how we are going to tackle? Now, let's understand there is no specific treatment. If we can understand whatever drugs that we are giving it because they are still not USFDA approved. We still don't have any robust evidence that this combination of things do work. But then there are certain principles which are going to guide us when there are women pregnant. We have to make sure that we are in close liaison with a multidisciplinary team. Of course, once there is a COVID, there will be news across your hospital. Everybody gets in place, your respiratory physician, the infection control, the infectious disease people, the neonatologist. Of course, the anesthetists are always there on the forefront, because we don't know which patient would need a cesarean section. Maternal and fetal monitoring has to be done closely. Of course, we're keeping the principles of an isolation as I've defined. They will definitely go to the COVID ward or the COVID area which you've defined. Infection control means aggressive. We don't want them to get, secondary bacterial infection because they are at a high risk. Oxygen therapy by nasal routes are preferred for people who are having even mild to moderate pneumonia. You don't want their situation to worsen. Fluid is a big challenge, and therefore you have to make sure, because kidney failures have been reported in patients, not in pregnancy, but otherwise. And of course, you give them empiric antibiotics. And in most of the data that I saw, they give them third generation cephalosporin, azithromycin, and also some other combinations are given in the Chinese, papers. You're monitoring them for labor with uterine contractions. Now, again, they say if we are getting closer to patients who are suspected, would we get, I think, a CTG monitoring is the safest. You can put the CTG and it'll be doing the reading rather than you go closer to the patient and hear the fetal hearts. Now, again, the threshold for mechanical ventilation has to be much lower in a pregnant patient, unlike a non-pregnant, because we know the physiology of pregnancy is different. Now, what about delivery? If she's a defined COVID, should you do cesareans as the Chinese people did? I think, again, it is very debatable as of now. We are very, very, no, we're not sure. In fact, the patient who delivered COVID positive patient in our hospital, we had all discussions, and then we still took her for a cesarean section, though she was not having pneumonia. She was stable. But then the fears were, she's stable now. We don't know if we leave her, how she would be. That will be the next question. And again, all of us are just collating data which is coming from few cases. But yes, there is absolutely no reason to take and make COVID as an indication for cesarean section. In fact, vaginal deliveries have been there. And the paper from the US, one case report from NEGM, which I will share you, was a lady who delivered vaginally and had nobody in the health workers positive. Yes, critically ill patient, where we understand that we are a threshold and we are going to shift them to mechanical ventilation. I think these are the patients who should be allowed to go for a cesarean section. Here, again, your anesthetist would be the best people to help you. And continuous electronic fetal monitorings should be offered, provided facilities are there. Now, mode of delivery, again, it said that should you cut short the second stage of labor if to prevent? Yes, this is recommended by one body. It's not recommended by the other. I think, again, you have to be judicious depending on what the mother's status is. Can she push down? And she's like, is not having severe respiratory symptoms, then you can allow her a comfortable delivery, but make her comfortable. And as I said, that even though we don't have a scientific rationale as of present, I think it will be your local preferences and local practices. And in this present time, when people are not very confident, most of us are resorting to cesarean section. Now, I just want to share this case report which came from the US of a vaginal delivery of an uncomplicated delivery in a COVID-19 patient who was 34-year at 39 weeks, who presented in labor at the delivery units, and she had just a 3 days history of fever and chills. Now, mind me, when she came, she had an X-ray chest, which was consistent with COVID-19, though her test had not come, it came later. But because there was a suspicion, she was taken up to the labor room with a CT scan because she had symptoms of dry cough and fever, and the contractions were augmented with augmented. And she went into labor. An interesting bit, the reports of her COVID test came 21 hours after the samples were obtained. The temperature was not very high before delivery. However, she developed, the fever went higher when she delivered in the postpartum. And interesting thing is, while delayed call clamping is advised by the RCOG, the ACOG or the ACOG and the CDC don't recommend. So they did an early call clamping. And what is important is that the skin to skin contact was not permitted, because the fear is the neonate may get infection while it comes close to the mother, and therefore from the droplet infection, the neonates may get infected. There was no evidence of intraamniotic infection or neonatal infection, as they got from the throat swabs and the amniotic fluid virology. And this neonate was on expressed breast milk. Now, breast milk was given, but it was expressed. And the beauty is 7 days after delivery, there were no caregivers who appeared to be infected. So all the precautions taken, delivery vaginally was successful. And this is one of the few vaginal cases of vaginal deliveries. So if we look at the FOXI guidelines, they are for patients who are confirmed with COVID and pregnancy. Very important to give the patient a mask. You should have all the PPE in place. The healthcare workers should be using PPE, which is at the level 3, or this thing that has been defined by CDC. If there is an obstetric emergency or an active labor is a decision. If she's having if she's stable, then she can go to your COVID designate area, which could be a labor ward, and then can be transferred later. But if she is definitely in labor, she is having, to go, then decisions are taken. But if there are no symptoms of labor pains, then we can assess the symptoms. And the very important thing is she can be sent back, even if she comes with false labor, to go home to recover. And maybe by the time she comes back, we can have a delivery. Now, the ECOG, again, to guidelines, the American College of Obs and Gynae clearly says that if there are patients who have, and this has just come recently, which is coming as not as guidelines, but as frequently asked questions to the clinicians, they say that if there's a patient who's even at 38 weeks comes to you for a checkup, there is no hurry to do a cesarean section as elective. If she's COVID, let her settle, let her come out, give her 40 weeks or maybe 41 weeks, because fetuses will not have any compromise in terms of IUGR, and you can get back at 40 weeks plus and then take a call on them. So labor management, I think, is a very important area. It's a designated area which labor or delivery will take place with isolation. Very important, you have to minimize the number of people. Healthcare workers are important, are your anesthetists, of course, a pediatrician, your nurse, but keep them to the minimum. Of course, there is a restriction on the birth of, companions. So whatever we say, and this is a particular time, if they are there in the labor ward, they have to be given a PPP as well. Monitoring is, again, as high-risk patients, you do their input-output charting. They take the fetal monitoring as per protocols. Of course, the use of anesthesia, we'll talk in the next slide, is sort of epidural analgesia is not contraindicated. The mode of delivery is as per your guidelines, but cesarean section as for obstetric indication. And I'll just say, again, it's on the individual, site. Of course, delayed cold clamping is what the RCOG says, unlike the other guidelines. So the ECOG says early cord clamping, RCOG says a delayed at 1 minute. So I think they're just a school of thought, but then I think it's your choice how your pediatrician says. Now, when it is the OT, it's a cesarean, again, it has a designated area. What is very important, again, there are guidelines from the WHO, CDC on the OT area, which has got a negative pressure area, minimize the movement. Anesthesia is preferred as regional because we know their lungs are compromised, so why take the risk? Suppose there's a crash cesarean or there's a failed, spinal, then I think you have to make sure the anesthetist, who is the senior most, is there. And in fact, you should have senior people right in the team. Antibiotic prophylaxis is there. And you have to prepare the team in case there's a crash cesarean coming. But then in that case, you have to even prepare the patient's relatives, that there be a little time when is involved in preparing that kind of a situation. Of course, post-op wards are very important. They have to be, again, as per standard protocols, nursing, barrier, and these are standard universal precautions to be taken for any COVID positive patient. Now, the next question that comes is, what about giving them drugs and medications? We're talking about antibiotics. What about the antivirals? What about chloroquine? And now this is what is called as the monitored emergency use of unregistered interventions, as they've been put up by the WHO or the CDC. That means these are drugs which have not got US FDA approvals, but they are being given as ethically. Are we right? Of course, ethically, we are being justified to use them as non-licensed drugs because they are not approved to be used in pregnancy, particularly hydroxychloroquine and chloroquine. So this is what is there, and this is what I could get for pregnant patients who they've used. In fact, if I looked at the Chinese papers, it was interesting that they did not only use antivirals, they even used, in some cases, 1 or 2 cases, ganciclovir. They have used interferons, because again, they were using some knowledge coming from their previous, experiences. They have used a drug called Arbidol. I didn't want to get them because they're not standards. And they have even used traditional Chinese medicines in managing patients. So that was interesting. And this is all in the papers from Lancet that I could get. But if you're using, now these are drugs which will only be used for a symptomatic patient, i.e. who has pneumonia, who is moderate disease and more. And that is giving them hydroxychloroquine. The doses are there. And when you do it, you give them in combination with azithromycin. Now this is already a trial which has been registered in the US. The trial is going on for patients, and some clinicians in New York have actually even published this, and from France as well. There's some trial which has been done, which have shown good results. Now, shown to give a virological cure in 6 days, and 100% patients were treated. The alternatives doses are also there. You can just go on. I will not, talk to them. They're all there available. But mind you, Azithromycin should always be added if there's a clinical suspicion of, in fact, to your patients who are, if they are afebrile or who are just asymptomatic, there's no need. You can give the standard antibiotic prophylaxis as per your labor ward or the OT. But if there is a slight suspicion of respiratory system, do not hesitate in giving azithromycin. Now, this is obviously some of the contraindications could be a D6PD deficiency and retinopathy. Now, what about the antivirals? Again, we don't have any robust antiretroviral which has been defined. I think the remdesivir, which is I mentioned last, is a broad spectrum antiviral, which is supposed to be safest. It's still under trial. The ones that were used by the Chinese were the lopinavir and the ritonavir combinations. They have used that. As I said, ganciclovir was also used in some of the patients. So we still are going to wait to know. But should you be giving it to all patients? Again, we are not very sure. Should we use them? Now, I think, of course, there will be a big word is on steroids. Because if you look at it, steroids are not recommended by WHO and CDC in managing ARDS, which develops from COVID. The reason is that there's a delayed viral clearance in these patients, and also because when the viral clearance is slowed, this will probably worsen the disease, is what it said if you use steroids. But then we are talking as obstetricians of using steroids for fetal lung maturity. And I think just a week back, the ACOG has given clear guidelines that if you have to give, for a woman, to a woman who is at risk of preterm labor, then the decision should be to give her, because at this point in time, giving a mother with a fetus, which is 30 or 29 weeks, is that the benefits are far more than the risks, even if she's having pneumonia and we go ahead and give. But mind you, must keep your infectious disease people and pulmonary physicians in loop that you're going ahead and giving them, because it's just being given for a transient, shots which are given. However, we would not recommend it to non-pregnant patients. Now, the analgesia anesthesia bit, I'm sure your anesthetists are there, but as I said, the epidural and spinal analgesia are not contraindicated. Epidural labor analgesia is rather allowed and permitted. Of course, if it's GA, your anesthetist will be well versed to take care. Of course, the video laryngoscopy is preferred to improve intubation. And of course, high efficiency hydrophobic filters, which are very important because they are between the face mask and breathing circuit, just as this is very important to avoid the contamination to the atmosphere. Now, I just said what to say about when they get back home and when they are discharged, they have to stay back. In fact, when the discharge policies are the same for a pregnant patient versus non-pregnant, as per the CDC, when the patient is symptomatically free, when she has 2 tests which are negative 48 hours apart. But when they're going back, you give them preferably a single room. If another family member needs to stay, should maintain all the social distancing. And of course, if you have elderly people, other people in the home, then they have to be sort of forewarned and put under, again, a strict kind of quarantine there. And of course, you have to avoid social gatherings, which I think in India is very important to say. Now, as I said, the triage labor room and the COVID, and this is again, I thought I'd get, because the FOXI guidelines have just come last week, that SOPs have to be in place in every maternity unit. And so what I've said, you have to alert, and these are all the things that are important, that if you get a call from a patient who's home, you have to send your ambulance or a private. You have to use, make sure that the ambulance is sanitized after she comes back. The driver who's taking the ambulance is well prepared, is having the PPE in place. And also when you're triaging, you are sending them to a place which has got negative pressure if she's a defined cohort. So all these things have to be in place. I mean, SOPs have to be there. Now, again, breastfeeding, of course, CDC clearly says separation. They say there is no, place of putting the mother and the neonate together. And having said that, they even say we do not know whether the mothers of COVID mothers can transmit it. And again, the current evidence is you have to see the best benefits of breastfeeding outweigh any potential risk of transmission. So having said that, doesn't mean you not give breast milk, but it means direct breast milk or direct breastfeeding. You can give it to the express breast milk can be given. And of course, there are do's and don'ts. There again, the frequently asked questions by health workers, which have been answered very well on the CDC. How should you kind of give the breastfeeding? If she wishes to breastfeed, she has to wash hands, she has to wear a mask, she should not sneeze. And the express breast milk with manual or electric breast pump are the best. And before she even expresses, she should wash her hands. This is something which is coming from the Royal College guidelines, because they say that the risk benefits are not very clear, because all the babies who developed it while breastfeeding on the 4th or 5th day had a mild. I think it's very much for your patient to take a call, and I think it will be judicious to give them both the benefits and the risks. But express breast milk would be a better way. Now, when the patient reaches to ICU, I don't think I can really be doing a good job on this, but an interventionist or a critical care person will be the best specialist. Of course, a multi-team disciplinary team is the best way out here. And I'm sure you should involve your people well in advance. And that's what's happening all over the hospital that we're managing. Our patients, of course, these are strict guidelines to push your patients to the ICU. Of course, when should you put them? The SOFA scores are there, but I think the SOFA scores may not hold very good the sequential organ failure assessment to pregnant patients. And as I said, the D-dimer or the IL-6 values may not be of benefit to patients in terms of severity. Now, I thought I would just share this. This is something very interesting. If you read, this has come in the FIGO, the International Journal of Gynae and Obstetrics. It's just a recent recommendation. It's an expert consensus which has come in managing pregnant patient and neonates born to mothers with suspected or confirmed novel coronavirus. And if you look at it, all the contributors are Chinese, Chen to Yang to Kao to Cheng and everybody. And the beauty is it's not just obstetricians, it's a whole team. Predominantly obstetricians, infectious disease experts, pulmonologists, intensivists, anesthetists, who have put their brains together. And they have given the so-called 10 recommendations, which I would say the 10 commandments. And they clearly say that this may hold good today, but we're not very sure. And as I said, my slides may also be outdated in the next week, who knows? But this is what they have given, and they have put their heads together from the middle of January until the end of middle of March for the 2 months, and putting all their case reports. And they put the first 5. If you look at, they give the quality of the recommendation and the importance. And the first 5 are basically importantly critical. So they are the criticality of these recommendations, and the quality is definitely moderate to high. And if you look at it, the medical centers should standardize a screening admission. In fact, I'm just reiterating, but they put it very simply and nicely: screening, admission, and management of all pregnant patients. And management should be coordinated. And I think very important according to your local, federal, and international. So what the guidelines may apply for Royal College may not hold true for me. So that's very important. Again, they should have a history, which is a triad, as we take a history of travel to endemic areas, history of fever, all that should be taken. Besides history of exposure, women should be screened, and those who are suspected should go and mind you, they are giving a lot of importance to lung imaging. But here, I think we'll have to go individualized on a case. Patients who's asymptomatic need not go for a CT scan. And they are all recommending a CT scan because CT scan has got a better accuracy in predicting, the evidence or findings of lung involvement. This is also a very high level of quality, and this is very critical to manage patients. Again, pregnant women who have confirmed or suspected should be screened by medical personnel who have got a good sort of knowledge on handling. And when they are positive, they should go to a negative pressure. So that the ward should be negative pressure, the OT room should be negatively pressured, because this is the way which is very important to take care. Of course, the negative pressure, whenever possible, the medical staff should take care that they are wearing all the equipments that have defined, the N95, the goggles, the gloves, before they can actually come in contact. And the next 5 are basically not critical, but yes, they are very important, but they're coming from low quality of, as against the quality of recommendation they're saying. Again, the timing is individualized. It is the mode of delivery has to be based on the routine practices or the obstetric indications. Pregnant women who need a cesarean section should be allowed a regional analgesia. And of course, it has to be a multidisciplinary team, which I don't think we are sort of can do away. Of course, neonates here is something very important. The Chinese and are again giving recommendations. This is taken up by the FIGO also, that neonates should be isolated for at least 14 days. And what's important is that they are recommending that the medical specialists and the medical professionals who should be managing should be strictly working in tandem with all the other colleagues. And the ones who are attending, our own doctors, our health professionals, should also be monitoring themselves for any fever or cough. We don't want to lose our people and our man force who are working behind them. And very important, they should be receiving a training. So it's something which they have put as high recommendation. So I think I would just end here and conclude that we are handling a very vulnerable group, and it's pregnancy, safety of the mothers, and of course the fetuses are. But what's important is that the obstetric management that I kind of looked up and I went through literature was basically based on consensus and the best practice recommendations. We are yet to say that this is a level A or a level 1A or 1B. But then this is what we have. We don't have very much efficacy available on antiviral therapy and also corticosteroid therapy, which will be evolving, and that's very important. And I think a key practice points is that our pregnant patients are not at high risk. That's what we can reassure our patients. The disease from them will not get severe. You have to have an SOP in place. You modify your site, your maternity unit should be modified. So create a facility within a facility. You have to educate all your patients who are not coming to your facility to stay calm, stay put wherever they are. You can teach them as the Chinese are doing. You can reduce their visits and reduce their consults. Teleconferencing is the way forward, at least for the coming few weeks. We have to give all our patients, the attendants, the healthcare workers, due respect with PPE. Train your staff well to be adhering and practicing your SOPs, and very important, keep track, keep records. I think if we had a couple of deliveries, look, we have to put them to publications, because that's how we'll make meaningful data, and that will compile to data. So I think I would just say these were the suggested websites that I had consulted in the last week that I got from Monday when Venu told me, Kunju told me to look in. And I think the ACOG has just added this 2-3 days back. Of course, the European guideline has been equally useful, and very useful was the Chinese CDC site, which was very good. So I will just end here with this saying that it's a tough time, but it never lasts. And I think the tough people do this. This is the famous novel by Robert Schiller, and I'm sure most of you would have read it, and you would agree to this. So thank you very much.
That was an excellent lecture. Now we'll move on to the comments from our expert comments from the seniors in Kerala. First, we will start with Paily sir. Sir, would like to hear your comments. Morning in the K4G management discussion, you talked about the so many guidelines which can be proposed. Can you just briefly elaborate on that? Paily sir, can you switch on your mic?
Am I audible now?
Yeah. Yes, sir.
Thank you, Kunjumaideen, and thank you all for this opportunity. That I should say was a wonderful presentation. Neena, congratulations, because you went right from the beginning, the microbiology, the pathogenesis, and the management. So you have left very little for us to comment on, actually. Thank you very much for taking time and doing this. Just a few points which I thought we should take from Neena's presentation. And it is reassuring to note that pregnant woman is not particularly vulnerable to the infection. That is very reassuring. And of course, not particularly vulnerable to death as well, because in spite of about 62,000 deaths across the world as of yesterday, we haven't heard of any definite maternal death, even though RCOG has come out with a report saying that some tabloid reports are there about one possible death. So otherwise, no maternal death in 62,000 in the world is quite reassuring. But then we should remember that the number of pregnant women reported are also so low. Only about 65 pregnancies earlier, which Neena said, and probably 147 as of now. So we should still be very careful. There's no doubt that the third trimester is the worst. And so if anybody in the third trimester is having infection, we have to be particularly careful. And what we discussed this morning was the importance of putting them all on the pulse oximeter to know how saturated they are with oxygen. And the oxygen saturation is anything below 93. Certainly in such patients, even if they are in early labor, I don't think we should wait thinking that we will go on to have a vaginal delivery. But having said that, remember about 80% of the women or men affected with COVID-19 are going to have relatively mild symptoms. So that is why we feel that still there's a scope to consider vaginal delivery in these patients. If at any time they seem to show low oxygen saturation or going to get worse, of course, we should have a low threshold to take to cesarean. That is how I will take it. One or two points I wanted to bring to Neena's attention are, you didn't mention about the treatment, whether we can give hydroxychloroquine. Of course, you have mentioned it, but the New England Journal report that you mentioned also, they treated her with hydroxychloroquine. What about the patient that you had there in AIIMS? I believe a doctor's wife there, one of your own staff, had vaginal delivery, and was she also treated with hydroxychloroquine? ICMR seems to agree with it.
So the patient, I will just get you, yes, the New England Journal Medicine has got, the patient did get hydroxychloroquine because there is reports from both America and in France. Now, when I looked at the Chinese papers and the Chinese case reports were having Dept defined, they hadn't given. Probably these were the earlier patients because at that point in time, this data was not coming in. So in the Chinese, from Chen, the Zhuang and the other papers, they have used antivirals. They've used antibiotics and they've used Chinese medication, but they haven't used on a single patient hydroxychloroquine combination because this work came much later, towards the end of January. And these are patients who delivered until the middle of January from the Chinese data. Now, again, in AIIMS that we had, our patient was asymptomatic, she was COVID positive. And as per our, consults with our respiratory physicians, we haven't given her hydroxychloroquine, but we've just given her the antibiotic, that's all. So she's been given the routine antibiotic prophylaxis. She's not having respiratory symptoms. But having said that, when I reviewed the literature, and of course, they don't recommend, if there is a patient who has a fever or she has respiratory symptoms, it is a good idea to start hydroxychloroquine with azithromycin. You would probably have the doses that they have given are the ones which are safe. The one that we look at, the kind of ECG changes that were reported in patients who took hydroxychloroquine were generally patients in the older age group. So our patients, if you see, are lesser than 40 years. So I think hydroxychloroquine stands a safe bet and therefore should be recommended. But our patient did not have any respiratory symptoms. But if there is a symptom or there is a CT scan or imaging suggestive of pneumonia changes, I think it's good to start ahead. Go ahead and give them hydroxychloroquine.
Thank you, Neena, about that. And the other thing that physicians warn us is, if you combine hydroxychloroquine with azithromycin, there is added risk of the QT syndrome. And so they say that you have to be particularly careful when you add azithromycin to hydroxychloroquine, which I'm sure you also may agree with.
Yeah, totally, because that's the case reports which showed QT interval changes were basically combination, and therefore there was a warning came from the cardiologist. Now, this was it, but then as I said that we are very naive of the drug treatments. And as I said that these are the ones which are not even licensed for use, particularly hydroxychloroquine and chloroquine. But then if you have in the face of a patient who is going to the ICU, who's on a ventilator, I think that bit of a risk would be worth taking for a patient to give her hydroxychloroquine than sort of realize, because this drug is known to work through the ACE, it's acting on the receptor level.
Anyway, we are safer because ICMR has okayed it. So
yes,
from that angle, we are all right. The other point I wanted to bring to your attention is our own experience here in Kerala. Our state nodal officer has advised us that almost 50% of those who were having respiratory symptoms and COVID positive had H1N1 as well. So he has advised that all our patients should be getting oseltamivir as a co-prescription along with hydroxychloroquine or whatever we treat because of this possibility. I don't know whether, I don't think it has been highlighted that much in international literature, but this is what we have found in Kerala.
So do you mean the health workers who are attending, just to give them as a
No, the patients who are positive and where we have to treat them, they are advising us to treat them with oseltamivir.
So oseltamivir is another promising drug. In fact, as I said, that this drug is also undergoing trials. For pregnancy, I could not get on. I did go review a lot of, put in antivirals, and I said I could get ganciclovir being given, but not on any of the newer, and these oseltamivir was not there. There was not any experience of using it in pregnant patients.
I was just mentioning what has been recommended to us in Kerala, that's all. Now, the other aspect is, what about the healthcare worker? Would you give them routinely this HCQ prophylaxis? Because we are all likely to meet patients who are carriers and won't reveal to us. And also, of course, we are at higher risk everywhere, every time. We cannot be using PPE. So would you recommend HCQ prophylaxis for us ourselves?
No, sir. As of now, there are no recommendations. I can't say ICMR, even in our hospital, as the SOPs go with the pulmonologist and our residents who are, attending on patients who are positive, we are not recommending a hydroxychloroquine prophylaxis. So that is not recommended as of now. I know there'll be many asymptomatic. Again, what is the big question is how long will we give HCQ AB? We don't know. This mayhem may go how long. So I think as of now, we are just going to stay put with all the, social distancing, taking care by wearing. You can see, till last week, even the US CDC did not approve of wearing masks, and today they are recommending us to wear masks. So I think we have to wait and watch before we kind of jump to say we will be recommending HCQ to all our healthcare workers.
But
it's a little
because,
premature.
yeah, but because you are in a position who is likely to recommend to the government and to the ICMR, I just wanted to put across this point. The ICMR has recommended it to those who are giving care, to those who are pregnant, those who are infected, and the caregivers also. Now we know that we will not be able to test everybody. There is a possibility that people won't reveal the history to us. And this is a drug which at the dose that we are prescribing, even less than that, actually a 400 milligram is supposed to give adequate lung levels for 3 weeks. So in this case, is there anything wrong for the ICMR to recommend it? Other than that, of course, you are worried about whether we run out of the stock.
Sir, your point is very valid, because if you look at the cost effectiveness, I think it's more effective. The cost is nothing. And we, at a country like ours, where we don't have a facility like Korea to go in for rapid and advanced and intense testing, I think in the face of fearing of the asymptomatic carriers that we are going to encounter despite our masks or despite our social set, it does make sense. But I think I'm a little premature. But yes, this point is really valid. But as of now, there is no, SOP in our place to give prophylaxis to our health.
You are the ones who are going to advise the ICMR and the government.
Yeah.
So that is why we are suggesting.
Yes, I think that point is very valid, and I should be able to sort of take this back. Thank you so much.
I think I won't take more time because we are constrained for time, but thank you very much for all that you mentioned. Only one point which I wanted to ask you about triaging, and then our own POGS guidelines suggesting that some of them can be sent home. I don't know whether it will be a very acceptable proposition in our country, because people are very unlikely to agree to go home, isn't it?
Sir, I totally agree, but then we have to look at our own, space that we have. And again, the confines of the home will be very risky, because our relatives, the kind of ostracization the patients are feeling, the way people may not be even willing to take her back home. I agree, but then this is the way we have to work, because we will be, in the days to come, we are walking a very tight rope. We don't know how many beds we need, how many areas we'll have to convert. And then again, there is, I think, if as most, centers across the world have done it, and if you look at the Chinese experience, which is amazing, you have the kind of guidelines they given for their patients. They have patients who were detected right earlier. In fact, in Korea, they've done this. They've put their patients at home, and they wanted them to recover so that they had sufficiently, energized, and they are sort of, again, the health of the patient is better when they come in labor. So this, if you look at the Korean papers and you look at the recommendations coming from China, they are there. But yes, in our society, we'll have to sort of understand. But then, keeping somebody who comes in the labor ward with 32 weeks and holding her back to 40 will be too much of a strain on the...
That certainly will not work out.
That is what will not work. It will be a too big...
Close to 10. That is all.
Yeah.
Thank you very much. Thank you, Neena, for this very wonderful presentation.
Thank you, sir. Thank you, ma'am. So now I would like request Dr. Sekharan, sir. Sir, please, your comments.
No, it was a very good presentation and a very good discussion following by Dr. Paily. Now, with the positive evidence coming in, I think we should be open for use of hydroxychloroquine for our patients as well as for prophylaxis of those persons who are exposed to this situation. That is one point. Then I could see that the vitamin D is having some protective effect in the activation of this virus. So it is to be given, sufficient dosage has to be given to all people who are pregnant at least the sufficient dosage to have a blood level of more than 40 nanogram per ml. That is one of the suggestions which was coming in. It may be protective for such patient and may be acting against the virus. That is one new thing which has been seen. Then about there are the anti-parasitic thing which was going to, I think, in the veterinary side, they are trying on that also. And then the use of, you mentioned about the remdesivir. There is another antiviral which is also available in India. So these are some of the hopes that we are looking at it, that we may have something to fight on with this deadly disease. And hopefully soon there will be enough evidence to suggest that it may be in place to use. Use of hydroxychloroquine in pregnancy, there was another paper that because of the volume increase, the dosage may have to be modified in pregnancy, which is, they say to start with, instead of 400 milligram, may be required to be given as 500 milligram twice a day to start with, so that there will be sufficient blood level. In young people, it has been used for a long time in India as a prophylaxis for malaria prevention also. It doesn't have much of a problem as such. And it was given in malaria areas. So every week it has to be given. It was Camekin, one of the other or chloroquine. Every week it was given all over India, in the northern part of India mainly. And it was given every week. So it has been in use for a long time. Hopefully, other than in old people with cardiac problem, renal problem, liver conditions, I think the young people who are pregnant are not having such serious illness, barring the severe preeclampsia and other things. If it is to be contraindicated, we do not know. But still, I think there's a good chance to now utilize this drug, which is found to be effective. It has been given, FDA has some special given yesterday or so to use hydroxychloroquine as a treatment modality, not specifically mentioning about pregnancy. So that is also coming up. So hopefully we are having something to hang on to fight this dangerous condition. So that's all as a comment. It was a very good presentation. We all learned so many things. Thank you for all the references of the CDCs and other presentation. Thank you very much.
So thank you very much. I think the vitamin D point is again new, but I have seen there's another clinical trial which is registered. This is again not with pregnant patients, in which they're trying vitamin C. And I think this is what I think is what we thought could be empirical, but there's already a clinical trial which has been, and they're giving vitamin C not solo, but they're giving in combination. So let's see, that is what we can give. It doesn't cost us, maybe 500 milligram of vitamin C could be there. And again, vitamin D supplementation should. So this is nothing which we can. And I think I also came across the report of anti-helmets, again, a trial which is underway by the US FDA has given it's a trial which has got a clinical trial registry number of a newer anti-helmet thing. So I think these are a lot of thoughts that are there. So we'll have to wait and watch. That's what I can say.
What's about BCG vaccine that has been mentioned?
Yeah, but I think, Kunju, that's right. There's a lot of news, but I think nobody has really validated, because in the subcontinent, that's what is the hypothesis, that they're saying that the Indians may possibly be less, affected by the disease. But then we can't really say till we have tested everybody, including the carriers or the asymptomatic people or the pre-symptomatic also, to say that this group who got BCG vaccine were protected. So I think it's a little premature to comment. But yes, the media is doing a lot of talks on the BCG vaccine. There's definite there.
Thank you. Now I request Rajasekharan sir to give the expert comments. Sir, please.
Thank you, Dr. Kunjumoideen. Dr. Neena, it was a very excellent presentation. As you highlighted, we have only limited experience, but however, the preliminary conclusions are really useful. And the happy thing is that pregnant women seems to be not at an extra risk, and the obstetricians as such do have the liberty to decide between cesarean and vaginal delivery. Then I just want to highlight one or two points, that is regarding the prolongation, the QT interval and the risk when you combine HCQ and azithromycin. That is only in patients where there is an added comorbidity such as hypertension or heart disease, this becomes very significant. Otherwise, in a healthy patient, it's unlikely that there is a prolongation. However, ECG monitoring is recommended. Another far-reaching impact on our healthcare system is really worrying, because if it is going to be a prolonged affair, then we have to reschedule our whole elective work, and a lot of money has to be pumped into control of the COVID. That means the whole system may have to be redesigned, and this is another very threatening impact of COVID on our healthcare system. Thank you, Neena, once again for that nice presentation.
Thank you, sir. Thank you so much. Madam, please.
What about any other questions? Could you?
Yeah, we have questions. Before that, we have few more comments. Now we move on to Professor Dr. Ambujam. Madam is the head of the Department of ONG at Government Medical College, Thrissur, and also the president of Kerala Federation of ONG. Madam, please.
Dr. Neena, it was a very wonderful, very elaborate and very informative talk on COVID, which is a relatively new thing for us. And it is very reassuring that the pregnant women are not at much risk for that. Now, actually, you said that till now we don't have any evidence on vertical transmission. But now recently some reports have come that there is IgM demonstrable in the baby cord blood. So there could be a chance for a vertical transmission also. I would like to know your opinion on that. And secondly, actually we were having a discussion in the morning from our Kerala colleagues and our seniors, Paily sir especially, we were having a discussion on the mode of delivery. Because unlike Hong Kong and China experience, we don't have much patients coming as COVID positive. And whether routine cesarean section for all of them is actually practical, or is it, and what we have actually arrived at a conclusion that we will keep a low threshold for cesarean section. What is your practical experience at All India Institute of conducting labor and allowing vaginal delivery? How often you will do a vaginal examination and all that? Can you just elaborate on that? Thank you.
I think what papers that have come have said no vertical transmission. And I put it that the very big caveat to saying it is that they all have delivered them from cesarean section. So I think vertical transmission doesn't happen. We really can't say, because they did them, even the ones who were laboring, they took, an early labor, or there was one patient who almost went in obstructed labor from the Chinese cohort, and they did a cesarean and they did not find. Now, the very big caveat again here is that they have presented, or they have published data for patients somewhere between the 32 or 33 weeks until term with the developer. So we really can't say what if the patient had an infection earlier in the mid-transmission and then she goes on to deliver. So that will also be taken, and that will be part of the vertical transmission. So I think we still will have more information unfolding and more data coming once we know that. But as of now, if the fear of vertical transmission is not there, then I think we should be using our own judgment and doing vaginal deliveries, because even from the vaginal deliveries that have happened in the NGM paper, they did not have the neonates being affected. So that is there. Of course, the 2 or 3 infants that have been infected are the ones which are not tested, but they say they probably had it because of their closeness with their mothers while they were put in the confinement. So I think it is a point which is to be really thought, that in a developing country like ours, and also in places where HIV, where we know has a vertical transmission, we have moved to allow them vaginal deliveries. Why not COVID? I think the thought is very important. So as a clinician, I would always say, yes, if the patient is laboring, she has a very good chance. Suppose she comes at labor, she's already 3 to 4 centimeters dilated. Why will I take her for a cesarean? She is a multi, she's a second gravida, had a normal uneventful vaginal delivery. She stands a very good chance to deliver vaginally this time. So I should not keep my threshold for cesarean low for such a patient who is anyway going to spontaneous labor. And in fact, if you look at the RCOG guidelines, I know RCOG was written much before they saw so many cases, and I don't know how many pregnant patients. They have even defined their criteria for induction labor, i.e. inducing labor with the thought of delivering them vaginally.
Thank you, Dr. Neena.
Now we'll move on to Dr. Ajit. He's the professor at Periyaram Medical College, and he has some experience of attending some COVID pregnancies. Today morning when I was interacting with him, he is mentioning that there was already some 5 or 6 patients at Periyar. Sir, Dr. Ajit, can you just share your experience? Dr. Ajit?
Thank you, Kunjamaydin. It was an excellent presentation from Dr. Neena. Hello.
Yeah, audible, please.
Hello. Okay. It was an excellent presentation from Dr. Neena. Then we have actually 3 cases, 5 cases. 3 are the first trimester patients and 2 are near time. And one of the patient, actually the EDC is very near to EDC. So we are expecting delivery any time. I have a question to Dr. Neena. Your patient actually had a cesarean section actually, or if it is a cesarean section, what is the reason for doing a cesarean?
Sir,
I think your patient had a cesarean section.
Yes,
no?
sir. Our patient had a cesarean section.
What is the reason for you selecting that cesarean section?
So again, she was a doctor's wife. In fact, she was not in labor. She was 38 weeks.
Okay.
We had the option of going ahead and giving her, putting her to her place, quarantine, giving her 2 weeks. And then when she comes back, and then, you know, we could have given her, as I said, is what is the best, you know, situation and scenario. But all of this was discussed with the patient. And also considering that the entire family was COVID positive, I think the fears that are in the mind was, what if she worsens? What if she has? Because as of now, she had no respiratory symptoms. She did not have pneumonia. So I think at that point in time, when you discuss, patients are also in the morbid fear, you know, of what happens. So everything was taken in consideration. So yes, if the patient would have agreed, she was 38, 39, we could have gone up to 41, 40 weeks plus 5 days, left her, the disease and the viral shedding would have reduced. But considering that she was asymptomatic and considering her status was good, I think they opted, they wanted to take the things in the right time, the right, you know, place, because the baby's, the fetus is mature.
Thank you, Dr. Ajit. And we have Professor Pratap Kumar from Manipal. Sir, would like to have your comments and experiences and suggestions. Sir,
Thank
please.
you, Neena, for the excellent talk. I happened to get invited suddenly by Kunji just now, and it's been a pleasure to be with all of you here. I just want to tell you what we have done at Manipal. We have divided our team into 3 teams. One team obviously does the deliveries, and we do it for about 3-4 days. Another team sits in the house. They don't come to hospital. And a third team does the wards and the outpatient. That means we are not exposed to the problems every day, because if the whole team comes every day and then there's one person tested positive, then the whole team has to go quarantine. That's another contribution I could do. People who could do that in your setup, please do that. Divide your teams into 3, and probably that will save you from further problem. And regarding hydroxychloroquine, I agree with Dr. Paily that probably ICMR could tell all of us to take it. But I think on the older age group, we have to be careful if you have some hypertension and so on. Because Dr. Sonia Malik had just mentioned in her typed version there that we are giving for immunological problems of recurrent pregnancy loss. We haven't had problems with hydroxychloroquine. They're basically young age group. I think that's the only thing I could do. Thank you so much for inviting me.
Thank you, sir. Now we have a lot of questions queued up. We'll start one by one. Sir has already asked about should all high-risk pregnancies be screened for the virus? What do you say, Dr. Neena?
Kunju, I don't think there's a remedy. What do you mean by high risk? Somebody who has hypertension, gestation diabetes, I wouldn't even recommend that, because if the guidelines on screening and whom to offer are very clearly defined both by the CDC for pregnancy and also by the ACOG. So and we know that pregnant women are not at a higher risk than non-pregnant individuals. So routine screening would actually apply as if becomes routine for every general population. So I don't think there is a reason to this thing. Our patients who are pregnant, if they're immunocompromised, yes, she should be offered, but not otherwise. Or if she's a patient with renal transplant, yes. But in situations like that also, they are triaging the patients. If they have some symptoms or a history of contact, that's when they are recommending. So if they mean a high risk like a renal transplant patient or who's on immunosuppressions or who are immunocompromised, does make sense. But any other patient who's high risk does not. Suppose she has previous 2 stillbirths or she has had recurrent pregnancy loss and she's high risk. Do I recommend her? Absolutely no. That will be a lot of workload. I know pregnant women are not very many, but then in the situation where we are again trying to understand how the disease works, it's also a lot of
Neena,
scare
I
that
think
people...
among the high-risk group, is it anemia complicating pregnancy? Do we have to take care of them? Little more observation.
So actually, yes, anemia we definitely have to take, because if you look at the at some of the indicators of ferritin levels and all, but again, pregnant women actually have low ferritin levels. That's what I'd say. But offering them screening for anemia would not be justifiable at this point in time. We should take extra precautions definitely for our patients, as we are doing, because they are the vulnerable groups. We are taking all care. But as of now, offering a high-risk pregnancy screening on routine would not be, which could be taken up even from the Indian context.
Another question is, if amniocentesis is indicated in a COVID-19 positive patient, can it be done?
Yes, amniocentesis can be done if it is justified, because when you're doing a procedure, you have to take all the PPE equipments and PPE precautions will have to be done in an area which is an OT or an area which is negative pressure. The people who are assisting you, the staff have to be taken. You have to make a preparation, which is like any procedure which is warranting for a labor or a delivery of a patient, because you're going to handle fluid. And B, if I would say that they did take amniocentesis, but that was during, term or at the time of cesarean section. So amniocentesis, if it's indicated, would be done.
And another question is it that immediate CS is difficult in view of time required to don PPE is the reason behind directly resorting to elective cesareans?
Not really, but yes, there is a very important point with the RCOG mentions in crash cesareans. Because this is where I can understand after reading the guidelines that there is a preparation for them or allowing, and there is, their recommendations are to allow vaginal delivery. So we know that donning the PPE almost takes 1 hour, even if for people, or maybe at least 40-45 minutes for people who are even trained to donning and doffing of the PPE. But that doesn't give us reason. But then they have clearly mentioned that there may be a delay for a crash cesarean. In that case, one has to explain to the relatives. That means the relatives or the patient has to be prepared. But yes, as you said, that all of us are naive, all of us are scared, and fetal or neonatal, health is the priority, and we have to assure that. So perhaps, the Chinese papers have clearly said that we did it because we were worrying of the the vertical transmission. A, B, we were not sure how the disease behaves, and C, whatever they did, they extrapolated the experience from the MERS, that's the Middle Eastern, and the SARS experiences, where they had a very, very high mortality to the tune of 25% pregnant women dying. And they did not want to take, because respiratory complications happened far too early. So before they could lose their patients going to ICU, they did it. So that was a reason. But I don't think that will be a reason. Yes, logistically it sounds, but it should not be a reason to take cesarean section.
And almost similarly, elective CS at 38 weeks is the safest way to deliver a COVID-19 patient. Is it right? Almost similar one.
Yeah, I think, you know what, as I said, all of us obstetricians are also very worried. What if the patient has an unpredictable labor? But that is the biggest thought. It's not about at 30 weeks. So this was a question which has been very frequently asked by physicians in the CDC. So they say that, well, again, this has to be discussed with the patient, because nobody wants to take a risk here. Landing up with problems during labor, because if the labor goes too prolonged, with your health workers sitting for 10 hours with PPE and then cesarean, and all those things are there. But as of now, if you look at, as I said, I reviewed each and every case report, all the 39 cases, I went through each and every patient's, the reason that I could understand. In 60%, they had a defined indication, like fetal distress or uterine scars. In fact, but their threshold may have been low, but they clearly wrote without hesitation that it was an obstetrician's decision mainly to do cesarean section from the Chinese data. So I think as we keep getting more experience, we can say vaginal, but as of now, I think we are erring on the side of cesarean section.
And another one, should you recommend one dose of Tdap vaccine between 28 to 32 weeks routinely, which most of us not following, which may provide passive immunity in early neonates against the flu?
Yeah, definitely. In fact, you know what? Again, I had seen that there has been a lot of hue and cry about influenza and flu in the US and even in China. So what they are doing as a policy, they are co-testing every mother, not just for COVID, but also co-testing for other corona infections, including the H1N1, and they did for flu. Yes, I think this is a very valid point, because giving a Tdap would actually boost the immunity and would definitely be. I think if you talk, you get so many good ideas, as Dr. Pratap was suggesting, and Dr. Paily has been suggesting. I think this is again a food for thought. And there's no harm. There is no, you don't lose, because Tdap would anyway give immunity to when you give it to the
And
patient.
another anonymous attendee has asked, in the antenatal OPD, how should we be in PPE or routine attire with mask? Many patients do not give truthful history of travel or symptoms.
Look, in a routine antenatal, as I said, you've tried, you've asked them on phone, they're not running fever. It'll be a overkill to wear a PP in a routine antenatal care. It'll be a kill, you know, because you will, at one point in place, we are having states and governments begging for PP for genuinely needing. And here we are resorting to a luxuries like, you know, I would say Hitler said, well, you have with a famine, there's no bread, there's a go eat cake. So we don't want to create a situation like that. It will be, yes, for a routine antenatal where you have just seen patients who have no symptoms, no history of travel, no fever. I don't think it's justified to give PP. Yes, wearing a mask is good enough. If it will be a good idea to wear rubber gloves because you are touching surfaces. And again, there's a big fear. People have asked us, my residents have asked, they could be asymptomatic. When we are hearing a stethoscope, we are getting closer, we're getting and bringing our, you know, so close, we're getting our, you know, face or head close and our ears and all close. How do we do that? This is something which is again very genuine. And I think it will be a good idea if we can have a doctor tone or maybe a CTG machine to the other people are. As it is, the attendance is low. But we can, but then wearing PP is not justified.
And here the concern is genuine because the patients won't be giving the exact history of travel or the symptoms. And another question, any specific antibiotic protocols for the newborns of COVID-19 patients?
Well, there is, again, I will have to get back to my neonatologist for that, because we are not giving any special antibiotic. Of course, I did review the paper, which has come from the pediatrics group with the 10 Baileys that they have given. They took their throat swab for COVID, and they did not cover those neonates with antibiotics. Yes, a large number of them went to the ICU for respiratory distress syndrome. They were put IV fluids. They went to the NICU, so they were given definitely a cover with antibiotics, and that was injectable antibiotics, but not a patient or not a neonate who is healthy and has come without any symptoms or without any complications.
And regarding hydrochloroquine is also recommended in unexplained RPL, hence can be considered in pregnancy. And that's a comment by Dr. Sonia Malik.
I think I really
regarding the prophylaxis of the all healthcare attendees.
I think that's what Dr. Paily also recommends. We don't kind of lose much there to give, and it is a safe drug, because when we're giving to these patients, they are low risk patients. They don't have any underlying cardiac disease. They are all generally lesser than 40, 41. So I think it's a very valid thing, because you look at the safety versus the risk, the benefits versus the risk. With the dose of hydrochloroquine, it becomes maybe a food to thought again, that we can give to at least all the healthcare workers who are exposed to.
Yeah, then what should be the dosage of vitamin C to be added for all pregnant ladies in this situation?
I think there is again no defined doses that I could left up, but they've just said prophylactically you could give 500 milligram once a day of vitamin C.
Here also Dr. Sonia Malik has mentioned to add zinc to the vitamin C.
Yes, yeah, there is also some work where they're saying zinc is the one, because the zinc works on the pathways of the ACE2 receptors, and therefore zinc is another study which is again I could see. But I went on to the trials. I thought of in the last 1 or 2 days, I went to the clinical trials registry of the US, and I found there's another trial which has come on zinc, because they've seen that the pathways through which zinc could impede the actions of the virus through the ACE2 receptors.
Can I ask you a point, Neena? Am I audible?
Yes, sir. Yes, sir.
Yeah, in the Government of India recommendation, which came out recently, they said not to use latex gloves, only nitrile gloves. Any particular reason? Because you may be the people who have been recommending it. Any particular reason why latex, other than, of course, allergy?
So I really don't understand. Yes, nitrile gloves have been recommended over latex. I
No, but
just
they
don't know.
positively said not latex gloves. That is what wondered.
Yeah, and you know, even in most of the CDC, I think they just mentioned rubber gloves. They're mentioning not latex, they're mentioning rubber gloves very clearly, especially for health workers who are handling surfaces or where they're putting, if you see the cartoon I got from the first level 1 of PPE, where they're saying masks, but gloves, and that level, they're also recommending rubber gloves. They're not recommending latex. I also thought, you know, but yes, the government of India is recommending nitrile. I think I'll have to ask people from the virology people if there's some particular reason or for fomites.
One other point is about the negative pressure rooms and theaters. You know, that is something which is very difficult to get because most of our hospitals are not built like that. And to convert to a negative pressure is not going to be that easy.
Sir, I totally take your point. In fact, that's the reason to create our COVID facility. The trauma center has taken a long time. You know, it is easier said than done. Even in the best centers in the NHS, when I was discussing with my colleagues who are working, they have not been able to generate. In fact, for that matter, I felt many of our hospitals are better equipped than the NHS hospitals in those terms of creating the negative pressure rooms. And so the patient whom we delivered was a little before the COVID thing came up. So we had to deliver in an isolation area, which was not a negative pressure area, because we had to do with whatever, in the circumstances, the best that we could give. Obviously, this was an area which was identified as an isolated area, which we could handle as a makeshift before things happened. But I truly agree. It is easy to say create a facility and these are the guidelines, but you know, your engineering section, getting the filters, changing the air handling units is a very mammoth job. It's not going to happen overnight. That is for sure.
And there is a question from Dr. Shamima from Kochi. That's a very pertinent question. Impact on mental health of both pregnant women. Effect due to isolation from relatives as financial and difficulty to access hospital facilities, and the impact of the situation on mental health of doctors.
Absolutely. I think this is something which we are kind of neglecting in the present. I still can't say neglecting. There are a lot of people who are writing on it. There are loads of paper which have come from the journals, and they are reviewing the questionnaire, looking at data, how patients are perceiving this kind of, those who have tested COVID positive and who have come out of it, and their families. And I say, if you think of it, a lot of our patients, at least I follow all my antenatals, the ones who conceive after an IVF and infertility treatment, as it is, are a bundle of nerves. So for them, not to see their doctor or not to take the advice is very difficult. But yes, we have to give them some reassurance. And I think some kind of mental health, some kind of apps are what we could, include in our, not just talking to them on iron and calcium, but if you give them some app-based, because today we are app-based, we are app-based on Zoom today. So if we could give them something like mindfulness, I think that would really reassure, because as one point in time, if the patient is COVID positive, why are we sending her home? I think the reason to send people home is they would be better in the confines of their family. At least they'll be reassured to see people than sort of, stay alone in the home, and they're surrounded by the same kind of people who are only COVID positive. And of course, I think for the healthcare workers is far more important. I think all of us are nerved and psyched because we think of death, which is the ultimate end. But then I think there is something which has to be taken care. We need not just the words of reassurance, some kind of mental care that is to be needed for especially our healthcare workers, our nurses, our staff, who are there around the clock.
Neena ma'am, just
please.
Point. Could you make just one point? Yeah, Neena ma'am, forget COVID positive patients. We were discussing this morning. There was a lot of confusion and fear among doctors that lockdown is lifted. Once the lockdown is lifted, then and what should be the level of personal protection? Should it be increased? That was widely discussed. We were discussing this morning. You have any views on that?
Yeah, I thought the same. Once the lockdown is lifted, will the people come back with the same, fervor and energy and undo? And so I really went back to read a little bit of social science papers from China because, they have moved ahead and now they were in complete lockdown in Wuhan and places, and now their life is coming back to normal. In fact, they've even opened some of their, seafood markets and things like that you hear from the newspaper. But the beauty was, some of the journals, when they're recommending, they're still telling their patients to refrain and come back to the routine antenatal care. Also telling them because they are worried about the second wave, which could come. So I think these are all what, if you read on the, Wall Street Journal and others who are talking more of, economic, and they're running in tandem. They're drawing their dashboards. But if you read the Chinese work and the Chinese recommendation, Chinese papers, who are basically, again, related to the social science, they are still telling their patients not to come back to their routine as of now. So again, that will be a big mental toll on our and psyche of our patient, who's actually been in so-called cut off from a clinician. And I think our patients are the same. They want to see the patient more than they want the teleconferencing. I think a hand on her tummy gives them more reassurance, and even if her level 2 is normal. But I think somewhere we'll have to sort of, do a lot of counseling and help to our patients, because we don't know how the disease may behave in the next couple of weeks.
Okay, there is a comment from Dr. Sonia Malik, that is most societies are forbidding IVF. Given that this disease is here to stay for some time, should we review these guidelines since pregnancy does not increase the risk both for the mother or baby, or is it too early to comment?
Well, I really understand that the reason why, again, today the ASRM, yesterday or day before, there was an ASRM clear-cut guidelines which has come in the fertility study on the do's and don'ts. And it says said that avoid IUIs, IVF, and it's a big 3-page document that has come on fertility. I think the reasons why they are deferring is not because they are not understanding what will be the effect on pregnancy in the early implanted embryo and things like that. I think they're doing it for the reason of social distancing. And since every elective procedure is forbidden, I'm sure so would be IVF. But then if the disease is here to stay and it's long, I think we'll have to think of maybe going on for freezing embryos and then think of putting back, because should IVF stimulation and ICSI or whatever procedure you should not be, affected by the COVID infection as such. But then we are here to wait and see, and maybe convert to freezing cycles if the patients are agreeing, and then go in for a frozen thaw cycle later on. That could definitely be a thought.
And another question is, was the patient delivered in AIIMS by CS given antenatal corticosteroids? The question was by Asna Ashok.
No, she was not giving antenatal steroid because she was beyond 38 weeks. And if you understand the ACOG, because there is a big debate whether we should give steroids to patients who have COVID. Now, again, if the patient is having pneumonia and she is to be given steroids because her pregnancy is at 31 weeks and she stands a risk of going into preterm labor, definitely antenatal steroids will be given, because the benefits of giving steroids will be far more than the risk of that steroid harming or delaying the excretion of virus from the lungs. So go ahead and give. But if there's a patient who's 38 weeks, there is no point of giving her steroids. You don't gain anything, even if she was having a pneumonia. Our patient did not have pneumonia, but for somebody who had pneumonia at 38 weeks, there was no point giving her antenatal steroids.
Another is, kindly suggest the labor monitoring protocol for a COVID positive patient in labor. Does a doctor who conducts delivery or CS with complete PPE gear need any form of quarantine?
Okay. The current guidelines on monitoring labor is CTG-based guidelines. CTG-based monitoring is there if the facilities are available. If they are not, then you'd have to go for an intermittent auscultation as you're doing without a thing. I think that's perhaps the reason why we are resorting more to a cesarean, because people are not sure that with the PPE, how successful will be there to put in their stethoscopes and go and hear the fetal heart. i.e. CTG facilities may not be available. That's what was, because I went around when I read, I know the patients who have come from the initial work, which has come in the NEJM also, and also from Lancet papers, came from very tertiary hospitals. And of course, in China, they referred all their patients to only 1 or 2 facilities in Wuhan. So all the papers are coming from those 2 or 3 teaching hospitals. Probably all the COVID patients went there only. But I think the reasons why people would be resorting more, or the threshold to resort, would be logistics. But having said then, the RCG has clearly put in a CTG-based fetal monitoring. Probably they have CTG monitors in each and every labor room there.
So another question, is it recommended to give hydrochloroquine prophylaxis to asymptomatic pregnant women nearing term?
No, as of now, no recommendation because she's asymptomatic and we are not testing asymptomatic people. So in such a scenario, we should not. We have a patient who's delivered with us with the COVID positive. She's asymptomatic. We have not given her as well because she's stable. She doesn't have fever. She's contracted from her husband. But we are monitoring her very vigilantly. At any point of time, she develops pneumonia or symptoms then. And as the pulmonologists are closely involved, we haven't given, but with a patient who's positive. But on the other side, there's somebody who's asymptomatic, she's near term. I don't think she's anyway like a health worker who's exposed. If our exposure risk is nil, she's staying home, she doesn't have a positive contact at home, I don't see any reason to give her hydroxychloroquine.
Another comment from Dr. Sonia Malik to Paily sir. Don't you think we should also start publishing our experiences like China? Should we be starting a registry of COVID and pregnancy in India or maybe Kerala? Sir, your mic is off. Please switch on the mic. Yeah.
Yeah, certainly we should collect the data of the patients we have managed. But thankfully, so far, the patients in Kerala, for example, now we have 6 patients mentioned. Only 2 of them are in the 3rd trimester, others are in the early pregnancy. So, but even then, we have to start collecting the data because there can be variations from what the Chinese have mentioned because they used Chinese medicine for all of them. We have our own, there have been papers which say that our genetic makeup is different. We have probably some inherent resistance to this RNA virus, or so many things are there. So I think we have to keep our data. And I would urge Ajit, who is the one with maximum in India now. So please keep the data of all this. And so we'll be able to take advantage of that. Sure, Sonia. Yes, we have to.
And there is a comment from Dr. Ranjana Sharma from Apollo, Delhi. There is a guideline from RCOG circulated just 2 days ago. It says because of the changes in the immune response in pregnancy, there can be a more severe response to any viral disease, and same is with COVID-19, and there is a possibility of vertical transmission.
Yeah, the guidelines have been updated, and I think on the vertical transmission, the RCOG guideline, if you read in detail, also mentions, unlike the Chinese work, 2 of the neonates which are infected, they haven't commented, but they put a bit of, a question mark and query that vertical transmission has yet to be looked into with the disease. That's definitely there. But as I said, that this is too preliminary to say that the disease is free of vertical transmission because, getting from whatever babies that to delivering from cesarean sections will be rather very premature to say that it does not happen. But yeah, there is, the guideline definitely says so.
And once lockdown is lifted, can we conduct regular antenatal OPD or should we wait for more?
I think that's a very political question and don't think I'm in a position to say so. And as I said, I was reading the Chinese papers which have come from there, and they are still following in Wuhan. They are still following the regime. In fact, they are far more vigilant and the recommendations are just 1 visit per trimester, which is 3. And they're saying, but then they mention it is for patients who are singletons, who don't have risk factors. And they say for even twins, if they were calling the patients once in 2 weeks, they have to call them in once in 4. So even they have put the guidelines for twin pregnancies and singleton separate. So they are still following the old rule and following. But yes, should we really, do that would be the take from the epidemiologist. How do they fare?
Yeah.
If I may add a point there, am I audible?
Yes, sir.
Yeah. I mean, what already we heard from Neena, and all of us should remember that this is based on the evidence we have so far. This can change every day.
Yes.
And one thing. Second thing, the risk of this COVID for us in India, don't think that we are just over the cliff, over the peak. We are probably still to get the peak. So we have to be very careful. We may take away the lockdown, but we have to be really vigilant. Even in Kerala, where we started the lockdown process earlier, we are very worried that there may be another wave, and especially if other states near us are going to peak later, we will have its repercussions here. So all of us across India have to be very vigilant, because this is going to be in the community, just like H1N1 did. And until we get a vaccine, we have to be really very vigilant. That's what I would.
And there is a question from Dr. Abdullah, KM Abdullah. Is there any restriction for ultrasonography in pregnancy with COVID?
Yes, I think as the CDC says, and from the Chinese papers I saw, I think they've just restricted the ultrasounds in pregnancy, because, there's one thing very important. We have just talked of patients who are third trimesters, beyond 36 weeks, or at the max earliest was 31 weeks, who delivered preterm babies. There is a bit of concern, and this is something which I say there are a lot of unanswered questions as of now, and I will come back to the ultrasound thing, is we don't know what will happen maybe 6-7 months down the line when the patients who are infected with COVID the first trimester to deliver their babies. So, we'll know whether it has got an effect like the Zika or like whatever vertical transmissions. But having said then, as of now, the CDC says it should be judicious at the discretion of the clinician or the physician. But the Chinese people have made very clear, recommendations, and it is in one of the journals which I read was that just 3 scans is what they recommend, an 11 to 13 week scan. And that's what the Wuhan says, tell the patients to come only at that visit, not even to come even for a 6-week dating scan. Second scan is a 20 to 21 week scan if there is COVID there, just for her, and the sonogram for her, screening her anomalies and the genetic sonogram. And they say that a sonogram between 32 to 36, in fact, they say around 32 weeks, that's when she comes for a visit. That is what they're saying for all the low-risk singletons. So they have defined the number of scans that they add. And for fetal surveillance, the CDC says that as minimal as you can, depending on the need. So no routine growth scans, no routine, and in fact, the word is elective ultrasounds to be abandoned, or not to be postponed, sorry, not abandoned, elective ultrasounds to be deferred and postponed till further, lockdown or whatever is opening in US.
There is
hello, Kunjamaydin.
Yes, sir.
Hello, Kunjamaydin.
Yeah, yes, please. Yeah, please.
I just want to add that what about the breastfeeding? Because we don't know how many patients now in the future come. So what about the breastfeeding? Whether we have to allow, because the social distancing, nothing like social distancing in this issue. So what about that? Any thoughts, seniors?
Dr. Neena, please.
Yeah, see, I had reviewed breastfeeding very extensively. So, they did check for the virus in the breast milk. That is first thing. So when they did check the breast milk for virus, there was no virus in the breast milk. Serially that they did from studies from China, and even Korean works. But then the China and both the American societies are forbidding the baby to be kept with the mother for at least 14 days because they know the mother is COVID positive. Most of their patients, if they looked at the history, they came with fever in the 3 days. The maximum duration of fever was 5 days antedating the delivery. And 2 or 3 patients developed fever in the postpartum. They just had cough and some respiratory system and no fever. So keeping that, and we understand that the viral shedding is maximally in the 2nd week. It can happen even in the 3rd week. So 2nd week of symptoms. So with that thought, and they're not knowing the understanding, they try to distance the mother. If I read the Royal College guidelines, it clearly suggests that this is again to be at the discretion of the mother, and the mother who wants to breastfeed may do so. And they have suggested, because the benefits of breastfeeding, of course, in a society like ours, will be far more than, expressed non-breastfed milk or express breast milk also. Because an express breast milk, they've said, is what the patient doesn't give directly, is she expresses as the breast pump, and then somebody feeds. That's the thought that they have given because of the benefits that breast milk have. But if the patient is educated, she understands, and she washes her hands well, wears not an N95, but even if she can wear an N95, it'd be good. But even if she wears a 3-ply mask, something like a surgical mask also is what they recommended, she could go ahead and breastfeed. So it's like in a country like ours, where we understand breastfeeding has much more benefit, but just the reason why they're trying to hold back is, again, you know, as the world literature says, that it's a disease which is affecting the older generation. But in India, we're seeing it in people lesser than 40 also. Again, they're saying in infants, the disease is very mild, whatever they've had from the closeness. So we have to really see and wait, because who knows, our infants may be able to take that kind of infection in a milder form, or may go into a severe form requiring a ventilatory support. Because the pneumonia that developed in the neonates post, confinement with mother was generally mild from the Chinese, experience. So again, I think we'll have to wait and watch. As it was with HIV, initially it was like no breastfeeding, and now we are everybody for cesarean, and today we have moved ahead with vaginal deliveries. We're allowing breastfeeding. I think the American organization or American Academy of Pediatrics would again suggest not to hold back breastfeeding, because in our country the benefits of breastfeeding are far more, and our resources are not that robust in terms of breastfeeding.
And the next question is, in an emergency situation, if we take the same protection like in HIV, HBsAg patients, how much is the healthcare personnel protected?
Well, a very difficult question, and that's what I thought when they said that we don't have the PPE equipment. I'm sure the hazards are much more, depending. In fact, they are defined, procedures where they say that if there are splashes, because the difference here is, unlike an HBsAg or an HIV, this virus is far more infective. It's the infectivity of the virus more than the fatality of the virus. So keeping that, if you're doing a procedure like cesarean, it will be riskier because you're handling fluid. There'll be splash when you're delivering the baby, even vaginally. So definitely, the way they've described the PPE suits best. But yes, you're in a situation when you don't have, then I'm sure this is the only way out to protect yourself. And if I have nothing and I have this only, then what do I do? But yes, in a situation where I have the resources, I have PPE, why will I resort to something which is meant for an HBsAg or an HIV? I think I have to protect all my health workers. In fact, they have again defined that the people who are doing intubation or who are more in for aerosol or procedures for the oral cavity anesthetists, they definitely wear. Yes, your scrub nurse who's standing distant may kind of do away with that ideal thing, but again, you'll have to improvise in the times to come with resources.
And since the testing is not rampant, all patients with fever and cough, we can take the sort of protection. What is your take on it, Dr. Neena? The question is from Dr. Gauri Devi.
Okay, yes, if the patient is running fever, that means she's a patient of undefined or undeterminate in her origin. We don't know whether she's COVID positive. We should take all the prophylaxis, and therefore such patients should be put in the gray zone area, as we have defined as our triad zone. They wait until they are defined, and we get the test in 4 to 5 hours, and then they are sent to either labor rooms or either places. But for a health worker as us, as doctors, I think we should treat her as a COVID positive. Who knows? She may be positive and turns out positive after 2 or 3 days. So I would take all precautions and say, yes, wear the mask and treat her as COVID if she's running fever or cough.
Yeah, thank you.
And when there is a pandemic, in a scenario, in a backdrop with pandemic, I will treat her as a COVID positive.
Yeah. And before concluding, on behalf of all the gynecologists from Kerala who is listening this webinar, this is a question to Dr. Venugopal, who is the Secretary of Kerala Federation of Obstetrics and Gynecology. So the organization, is the organization planning for any relief measures to the members, because we will be devoid of any payment, salaries or anything in coming months? Do the organization have any plans to support the members or to supply any?
Yes, Kujumadin. In terms of relief, we already brought out one Corona diary, and second recipe book is coming soon.
So we want the organization to put some money in our accounts.
My God, Kunju, you should not say so, please. Venu, this is not done.
So it's the work of all the
Dr. Neena, all our doctors in Kerala together contributed to form a recipe book.
So that's nice.
What we are doing in terms of contributions towards eradication.
It is there in your you can share it.
I'm sure the cookery book will get you more money than your routine, books that you get.
Yes.
It will be Kerala special.
Yes, we will copyright it, and whatever money is earned from there, Kunjumadin will get part of it as relief.
Sure. Anyway, I want to congratulate the organizers. Excellent. I think, Kunju, it was really an excellent experience. I think it was so well organized. It was so well organized without any, glitches and hitches in the whole process. It was so smooth.
Before stopping, see, Sonia Madam has clearly pointed out that the situation is not going to end at this point. Because even after on 14th, if the government withdraws the lockdown, they may restart it after 5 days for another 28 days. So the situation of everybody's situation will become very bad. So organization has to take care of it. That's the meaning of an organization. So I request Dr. Wahab to express the vote of thanks. Wahab, please. Switch on your mic, please. Wahab, switch on your mic.
Yeah, sorry. Firstly, I thanks to Dr. Neena Malhotra and the seniors, the legendary gynecologist of Kerala, Professor Sekharan sir, Paily sir, and Rajasekharan sir, Ambujam madam, and Venugopal, and Pradap sir, and all of you contributed to this wonderful webinar, and this made to a big success. And thank you all for attending, all the participants again, around 300 registered and around 100 and 200 all the time. So thank you all for attending and making this webinar a big success from Perintalmanna Obstetric and Gynec Society. Thank you. Thank you all.
Big thanks to the speaker, Prof Neena Malhotra, and
Thank you
all
so
the
much, Kunju.
comments by all the experts. Thank you so much.
Thank you so much, Dr. Paily, Dr.
Thank
Rajasekharan,
you.
Dr. Sekharan. Thank you
you.
so much for your comments. They were so valuable. Dr. Ambujam, ma'am, I think your
Thank you.
comments were so very useful for us to have some
And
thoughts.
many people couldn't log in because of the capacity was exceeded. So we'll have one more session in with the different concepts.
And you know what? In 1 week, the entire slides change. That week, the entire thing will change. And I won't be surprised because every day there's new data coming in. Thank you so much, Dr. Venugopal.
Yeah.
Thank you.
Thank you, Neena.
Thank you, Sekharan, sir. Thank you, sir. Paily, sir. Thank you,
you.
Venugopal. Thank you so much. Thank you.